Many people living with chronic obstructive pulmonary disease, COPD, also have multiple comorbid conditions. In fact, more than 85% of patients have at least one comorbidity, and around half have 3 or more. Managing COPD alongside other conditions means paying close attention to how inhaled medicines interact with multimorbidity. Let's look at the common COPD treatments. First up, inhaled corticosteroids, or ICS. If the patient also has asthma, continue ICS. Be mindful of infection risk. ICS increase the risk of pneumonia and tuberculosis. Avoid or de-escalate ICS in patients with recurrent respiratory infections or bacterial colonization. Think bone health, as ICS are linked with bone loss and fractures, particularly in women. If osteoporosis is present or risk is high, monitor bone mineral density and fracture risk. Watch glucose control, as ICS can worsen hyperglycemia. In diabetes or prediabetes, plan closer blood sugar monitoring and adjust treatment as needed. At higher doses, ICS may also increase the risk of cataracts and glaucoma. Next, long-acting beta agonists, or LABA. LABA are effective bronchodilators, but they can cause tachycardia and rhythm disturbances. Monitor closely when starting LABA therapy in patients with atrial fibrillation or other cardiac rhythm disorders. Then, long-acting muscarinic antagonists, or LAMA. LAMA improve symptoms, but they may worsen urinary symptoms, especially in patients with prostate disease or chronic kidney disease. These patients should be monitored for new or worsening urinary problems. Because many patients with COPD and multimorbidity are often on multiple medicines, the risks of polypharmacy and drug-drug interactions are high. That makes regular review essential. Practical action points for primary care include: 1. Review all patients with COPD and multimorbidity at least once a year and more often if unstable. 2. Screen proactively for common comorbidities such as osteoporosis, diabetes, atrial fibrillation, anxiety, and depression. Also consider gastroesophageal reflux, obstructive sleep apnea, chronic pain, and lung cancer risk. 3. Reassess the indication for ICS at each review and consider withdrawal if risks outweigh benefits and bronchodilation is still to be optimized. 4. Simplify treatment wherever possible to support adherence and reduce side effects. Reinforce correct inhaler technique at each visit and empower patients and involve caregivers where appropriate to manage the complexity of multimorbidity. 5. Document the plan and communicate it across the care team. In short, inhaled therapies remain central to COPD management, but their impact on comorbidities must be monitored carefully. By tailoring treatment, minimizing risks, and reviewing regularly, we can improve outcomes for people living with both COPD and multimorbidity. Now, time to solve a short quiz to reinforce your learning. A set of selected IPCRG resources will be available for you at the end of this breath.